The following animation was created with Associate Professor Caterina Marchio and Professor Ulrich Lassen. NTRK gene fusions are a genomic rearrangement occurring to varying extents across many pediatric and adult tumor types. The challenge is finding the patients with advanced cancer that harbor an NTRK fusion-positive tumor. NTRK gene fusion occurrence can be classified into low and high prevalence solid tumors. Low-range tumors are significantly less than 5%. These include the more common cancer types, such as lung, thyroid, pancreatic, colorectal, and breast cancer. High ranges are in excess of 70%, including rare solid tumors, such as certain sarcoma subtypes. Patients with tumor types that have a high prevalence for NTRK fusions are typically tested for the presence of a specific fusion using standard techniques. Each technique has its inherent advantages and disadvantages that need to be taken into consideration. In low-prevalence solid tumors, it's challenging to know upfront which patients may harbor NTRK gene fusions. However, there are a range of characteristics and predictors that may point towards an increased likelihood of NTRK fusions. Currently known factors or predictors are MSI high status, tumor mutation burden, and other oncogene alterations. Applying these factors forms an enrichment strategy that increases the likelihood of finding the patients that harbor NTRK fusions, equally ruling out the patients that do not. Now that patients harboring an NTRK-positive solid tumor are identified, which treatment options can they benefit from? 2 tyrosine kinase inhibitors with anti-TRK activity are available today. Larotrectinib is currently the most specific TRK inhibitor, whereas entrectinib is a TRK inhibitor which also has anti-ROS1 and anti-ALK activities. Both have demonstrated strong efficacy benefit with a manageable safety profile. The following case was kindly provided by Ulrich Lassen and illustrates the treatment approach with larotrectinib. The patient was diagnosed with stage 4 non-small cell lung cancer and found to be negative for MET, ALK, ROS1, and RET EGFR wild type and PD-L1 10%. He received 3 lines of chemotherapy and radiotherapy with stable disease as best response, with liver and brain metastases. An NTRK1 EPS15 gene fusion was detected by NGS from liver biopsy. He received larotrectinib 100 mg BID in the NAVIGATE trial, achieving partial remission after 2 cycles. He's still on study in remission after +2 years, with PS1 and only a few grade 1 adverse events. As cancers progress, they typically outsmart or overcome drug treatment. It's critical to identify when this is occurring and change course with new treatments. At progression, a new NTRK test should be performed to identify emergence of resistance mutations. In the case of resistance mutations, patients should be considered for second-generation TRK inhibitors, which are only available in a trial setting today. NTRK fusion-positive solid tumors are incredibly rare. Our challenge is finding patients harboring them. However, once these patients are found, they can benefit from TRK inhibitor therapy. Defining diagnostic algorithms by tumor type is a critical step to aid identification in the future.